two, one. Please start, sir.
Okay. Good evening to all the dignitaries. Good evening and good evening to Smita Kumari ma'am. Smita Kumari ma'am is consultant medical oncologist at Health City Hospital, Guwahati. So today in our clinical conversation in prostate cancer, our objective is to understand the treatment landscape of metastatic hormone-sensitive prostate cancer, to discuss the clinical updates in the management of MHSPC, to gain insights on evolving scientific narrative for darolutamide doublet and triplet regime in MHSPC and its implications for clinical practice in India. So with this, I would like to request Smita Kumari ma'am to give her talk on advancing MHSPC treatment horizons, darolutamide without chemotherapy and evidence. So with this, I would like to kindly request Smita Kumari ma'am to start her talk. It's all yours.
Good evening, everyone here. Now, today's topic of this is here. We have come here to discuss on the advancing MHSPC treatment horizon and darolutamide without chemotherapy. Now, we are coming to an evidence that is Aranote trial. This in India, approval status of available second generations ARI are darolutamide is approved in the treatment of NMCRPC patients and also in the metastatic hormone sensitive prostatic cancer or in combination with docetaxel. Darolutamide is also indicated in the treatment of the patient with metastatic hormone sensitive prostate cancer. Now, coming to the evolution of the drugs, the data which shows that in 2014, the chartered evidence was for the docetaxel with ART. Then came the Stampede trial, C2 with docetaxel in ADT. Then in 2015, then 2017 was Latitude trial of with Abitron plus ADT. 2018 was Stampede Arms G4 with Abitron plus ADT. Then for apalutamide 1, that came into account the Archies, enzalutamide plus ADT, and in
Madam, can you please off your camera, because camera the white is taking more bandwidth, so it will be easier for you. So if you can kindly switch off your camera.
I got disconnected. Hello, am I audible?
Yes, ma'am, loud and clear.
Let me think. Yes, we were discussing about 2024 ARANOTE trial in which darolutamide plus ADT was taken into account, and that there was another trial for ERASEC, that is darolutamide with ADT. Despite the treatment with ARPI plus ADT or docetaxel with ADT, a large population of patients with hormone-sensitive prostate cancer will progress to resistant castration-resistant metastatic prostate cancer. Unmet medical needs remain for an efficacious treatment to offer a differentiated and improved safety profile in the patients with hormone-sensitive prostate cancer without adding significant toxicity or with a low drug dose interaction potential. On this idea came Arasen phase 3 combination with docetaxel, already showed a beneficial efficacy and safety profile in MHS-PC patients with leading to the approval in India in 2023. Now, there has a darolutamide when combined with ADT would provide an efficacy benefit with favorable safety profile in MHPC patients as are demonstrated in global phase 3 ARANOTE trial with significant Indian population. With ARANOTE data, darolutamide has a potential to change the treatment paradigms as how it could be the only ARI which could be used with or without chemotherapy. Now, in this Arasen trial, darolutamide plus ADT with docetaxel was taken in the patients with MHS-PC patients versus ADT plus docetaxel. With ARANOTE trial, it is darolutamide plus ADT versus ADT to provide a new treatment option in MHS-PC without docetaxel. Now coming to this double-blinded randomized specific controlled trial, phase 3, in which the patients was obviously the MHS-PC. Histologically, it was adenocarcinoma of prostate, and they were taken into the visceral metastasis was also taken into account, and with may be present or may not be present, and prior local therapy may be present, and they were given randomized 2:1 randomized trial with darolutamide 600 BT plus ADT, and it was against the placebo plus ADT. Now we have taken into account the races, the reasons, the Gleason score. The most important was the Gleason score was more than 8 at the time of initial diagnosis, and then those patients were taken with serum PSA was around 21 was taken, and the metastasis with the initial diagnosis was also taken, and the disease volume patients, disease volume patients were taken 315 in darolutamide versus the placebo ADT of 168. The visceral metastasis and local therapies. Now it is the parts of where it has been done. It shows that this trial was done in China with 65, with India 61, Taiwan 15, Australia 21, and New Zealand up to 10. Now coming to darolutamide versus darolutamide plus ADT versus placebo plus ADT. We see that it is like median 24 months was taken. There was the patient was up to 52.1% in placebo plus ADT, while it was 70.3% in darolutamide plus ADT. Now coming to the subgroup analysis was done. It was that age was considered. The most important factor was the age, less than 65, with 65 to 74, 75 to 84, and more than 85. The PSA value was less than median, more or equal to the median, and PS score was also taken, Gleason score was taken, and rest the same. Now, the end point, the OS and metastatic castration resistant prostate cancer, PSA on progression, and the time to initiation of subsequent systemic therapy in prostate cancer was also taken as an endpoint, and the time to pain progression was also seen. Then it has shown that time to progression, pain progression, was delayed in darolutamide arm. At the time of primary analysis, OS data are immature. Since OS is immature, patients will be followed for the survival. All the remaining per protocol placebo patients were offered a crossover with the darolutamide after primary analysis. Now, with progression, the two things which we have seen in our practice is the progression to the castration-resistant prostate cancer and the also progression to the pain progression. These two were seen with this darolutamide, that pain progression was decreased after darolutamide treatment, and also the time of MRCP CRPC treatment was also, the time has increased. Now, delay in the time to pain progression can be a high importance to the patient and have not been demonstrated with other ARIs. Now, the PSA which we have taken at the time of starting the treatment was not after starting with we analyzed the PSA of less than 0.2 nanogram per ml at any time during the treatment. This was seen that darolutamide was achieved this PSA in about 62.6% of the patient, while in the placebo it was around reached in 18% patients. Now, time to PSA progression was also measured, and it has shown that 63% of the patient in darolutamide doublet arm attained PSA of less than 0.2 nanogram per ml. This represented
Madam, you are not audible. Your voice is breaking.
R progression in darolutamide.
Your presentation is also.
Am I audible?
Madam, you are audible. Madam, one thing can be done. Yes, now it is good, ma'am. As your
Yeah,
camera,
I've changed.
yes, as you close the camera now, the bandwidth will not create any issue.
That's okay. Now, we were discussing about the PSA at the any time during the treatment when it was 0.2 nanogram per ml. Then it was 63% of the patient with darolutamide doublet arm attained a PSA of less than 0.2 nanogram per ml. This represented our 69% improvement in the time to PSA progression in the darolutamide arm versus ADT alone. Now coming to subsequent life-prolonging anti-cancer therapy. The patient with subsequent life-prolonging systemic antineoplastic therapy, this was taken around 62 versus 203 patients overall, 203 patients were there. And with this, we have taken 66 patients with darolutamide plus ADT. Now coming to the side effect profile, any side effect that was considered was around 405 patients, and with placebo it was 199. The grade 3 or grade 4 AE versus grade 5 AE. So grade 3 and 4 was seen in 137 patients, with grade 5 was seen in only 21. Serious side effects were seen in 105 patients. Now, median treatment duration was 24.2 months in darolutamide arm versus 17.3 months in the placebo arm. The safety profile of darolutamide in ARANOTE trial was independent to the PSA response and consistent with the favorable tolerability first seen in ARAMIS and ARASENS. Now, the side effect profile which we have seen with darolutamide plus ADT is anemia, arthralgia, UTI, back pain. These are the common side effects which we see, and it was compared with both arms. The only side effect that was more with the darolutamide trial was seen was fatigue. Fatigue was around 25, and there was increase in creatinine in 21 patients versus 15 in placebo arms. Increased in UTI was also seen in 52% of patients, and anemia in 91, constipation in 42, hot flushes was also seen in 41. There is a hypertension was seen, and this was around 42 number of the patients. The vasodilatation and flushing was also seen, and few rare side effects like cardiac arrhythmia, fatigue, rash, bone fractures, coronary artery disease, decreased weight, mental impairment, heart failure, and mood disorders with cerebral ischemia. Now coming to darolutamide, extended median time to deterioration of FACT-P total score by 5.1 months versus the placebo. Darolutamide is the first and only ARI to be demonstrated clinically meaningful delay in the brain progression, overall well-being. Now with this, we can yes, with this graph also we can see that with darolutamide, this blue graph shows that it is around 16.6 months of median versus 11.5 months of median in placebo plus ADT. Now, the time of deterioration of FACT-P subscale scorer was done on the basis total score was taken, and then physical well-being, social and family well-being, emotional well-being, and functional well-being, prostate cancer, bowel symptoms, and urinary symptoms was taken. The favor that darolutamide was the overall score. The favored darolutamide. Physical well-being was improved, with social well-being also showed favorable with darolutamide arm, and also the functional well-being and the prostate cancer urinary symptoms was also favorable in case of darolutamide. Now, coming to the conclusions, that is, darolutamide plus ADT significantly improves the PFS in patients with hormone-sensitive prostate cancer. Darolutamide showed a benefit across all these secondary endpoints. It has shown that we have seen all the secondary endpoints. There was a very significant improvement with darolutamide arm. Darolutamide has also been associated with deep PSA response, regardless of base baseline PSA. Anything can be the baseline PSA, but PSA achieved less than 0.2 was very for a prolonged time in darolutamide. Darolutamide is also the first and only AR inhibitors to demonstrate clinically meaningful delay in pain progression, overall well-being, including the social, family well-being, functional well-being, and the urinary symptoms. The only that was more favored with the placebo arm was the bowel movements, that is more likely related to the constipation. Now, darolutamide had a favorable safety profile, as we have already seen in the trials. Darolutamide plus ADT without docetaxel should become an additional standard of care in hormone-sensitive prostate cancer. Thank you.
Thank you very much, ma'am. Thank you very much for your insightful discussion on aeronaut, as well as looking forward to you in near future for such wonderful discussion. So with this, I would like to request Duncan sir, if he can give his presentation now, and we will go for question answer in the next part after the Duncan sir's presentation. Sir, are you there? Shall I do the presentation for you, sir?
Why not?
Okay, I am just sharing sharing my screen, sir, now. Sir, you are not audible. Am I audible to you?
Yes, yes.
Okay, I am sharing the slide for you now. So with this, I would like to call Duncan Khanikar sir. He is the consultant medical oncologist as Guwahati SCF SCI now. He was earlier with Dibrugarh Cancer Center. Now he has joined Guwahati SCI. So I would like to request sir, if you can start your presentation. I am sharing my slide now. My screen is visible.
Yeah.
Okay. Okay, I'm sharing, sir. I'm sharing. I'm keeping my mouthpiece off. I'm just sharing. If you can tell me if it's visible.
Yes, yes. Uh, One second.
Sir, I think there is certain issue with my internet also. Please be online. I'm just trying to do that. Kindly tell me when to change. I'm just sharing it now. It's okay now.
Okay, can I start?
Sir, you can start now. I'm just sharing the slide now.
Can I start?
Yes, sir, you can start now. I am sharing. You can start now. I am sharing.
Yeah. First of all, very good evening to all of you. And I must thank Bayer Pharmaceutical for providing me this opportunity and to discuss a very important molecule which is making inroads into the first line setting of prostate cancer. So primarily we'll be discussing about hormone sensitive prostate cancer. Next slide. So we all know that prostate cancer has a very long course or a very prolonged journey, right from being a localized disease, then with gradual progression of the disease, we find that a certain biomarker like prostate specific antigen shows an increase in the value, and with time, if the patient doesn't take any treatment, this locally advanced prostate cancer progresses to a metastatic disease. But with treatment, primarily hormone directed therapies, they result in a very unique type of resistance that develops in prostate cancer. And because of the continuous pressure or build up because of the hormonal agent, it becomes a bit hormone resistant. So this phase is called castrate resistant prostate cancer, and castrate resistant prostate cancer can be non metastatic as well as metastatic, but this is created because of the pressure buildup as a result of different hormonal agents. And this phase of castrate resistant prostate cancer is fatal in the end, because with time the disease progresses rapidly, and this is where there is an unmet need in prostate cancer. We want better and better molecules in castrate resistant prostate cancer. So uh, we understand that the OS improvement is only in the range of 4 months once the patient develops metastatic castrate resistant prostate cancer. Next slide. So, whatever treatment we provide to our patients, our goal is we must delay this phase of castrate resistance. So, the more we prolong the development of castrate resistance, the more our patients will survive. Next slide. So, we have actually succeeded in a big way, right from the use of taxanes, and there was a time which we term as the docetaxel era, and it provided a jump in the failure free survival or progression free survival as well as the overall survival in our patients of metastatic prostate cancer or locally advanced prostate cancer, and there was a sharp improvement in the overall survival. Next slide. But yes, we cannot wait and rest just yet. We need to improve better. Now, as in many other malignancies, or for that matter, all malignancies, the burden of disease matters a lot. So, if the disease burden is low, and this is usually defined in prostate cancer as having less than 4 bone metastasis, and here we find that docetaxel, or for that matter, any hormonal agent, provides a very good failure-free survival as well as an overall survival. But the same doesn't apply once the patient has a heavy burden disease. And by heavy burden disease, we usually imply more than equal to 4 bone metastasis involving the appendicular as well as the axial skeleton. And here we find that the benefit that we used to see in the low burden is not there with the same treatment if we provide in the high burden disease. So once again, we must avoid this high burden state. The more we target our cancer patients in the low burden state, the better will be their survival. Next slide. So we have come a very long way, right from the docetaxel era, the stampede era, to the different hormonal agents or the androgen deprivation therapies that we have right now, from abiraterone to enzalutamide to apalutamide. So, right, and now we are in the state of using darolutamide, which is a far better molecule compared to its counterparts. So, with time and with each passing year, we are providing better and better survival as well as a better and better quality of life to our patients. But the problem arises here, that how to sequence our therapies and which treatment to use in the first line and which to reserve for the later lines. Next slide. Next slide. So this is again a reiteration of what we have already discussed. The high volume disease states, uh, in the high volume disease states, I mean, the improvement in overall survival uh, it varies a lot. It varies a lot. And in the low volume disease, actually the improvement in the OS may not be marked at times. So here we are on the lookout of a better hormonal agent in specifically in low volume disease. Next slide. So we actually started with a very good molecule called abiraterone, and that was specifically used in the high risk metastatic hormone sensitive prostate cancer. So by this we usually mean that these are probably hormone naive patients who probably have undergone bilateral orchiectomy. That was quite common in the past few years, in the past decades. But now we usually go for medical castration. And here we add up an androgen blockade, and this is termed as combined androgen blockade. And our favorite molecule for a very long time was abiraterone. So as you can see here, abiraterone was the first to show that hormonal agent can be effective. However, it is important to understand the treatment journey of the control arm when interpreting this data. So here we find that primarily abiraterone resulted in a slowing down of the biochemical recurrence. So if we consider PSA to be a very important biomarker in prostate cancer, abiraterone succeeded a lot. It reduced the rapid progression of PSA. Next slide. And with abiraterone, we got to know that we need to use a bit of steroids so as to overcome the mineralocorticoid effect. And this combination seemed to provide its own set of adverse events, primarily because of the long-term use of steroids. As you can understand, the development of hypertension, uh, even fluid retention, edema, as well as osteoporosis, as well as long-standing cataract. Next slide. So probably that was also a reason why we were on the lookout of better androgen blockade therapies, tried to move ahead of abiraterone. And so we had good molecules like apalutamide. And the Titan trial is a popular trial where we understood that apalutamide also provided a very good progression-free survival as well as an overall survival. As you can see here, the hazard ratio is very healthy, 0.65, and it seemed to work in both low volume and high volume disease. Next slide. No, go to the previous slide. And then we also used enzalutamide in the same setting. Whatever we are discussing here is in metastatic hormone sensitive prostate cancer. So these are in so as to speak in the first line setting. So enzalutamide also provided a very good hazard ratio and also worked in low volume as well as high volume, probably better in the low volume states. Next slide. So how to combine therapies to further improve outcome? Next slide. So we do have a very convenient study design in the form of Peace One trial, where we utilize de novo metastatic disease patients with high and low volume disease stratified with good PS, and it was almost a 5-year study. And they're randomized to standard of care group, one arm, another arm standard of care with radiotherapy, another arm with abiraterone, and another arm with radiotherapy combined with abiraterone. Next slide. And to summarize the KM curves here, we understood that in high volume disease, we could improve outcomes by adding abiraterone to docetaxel, so a chemo with a hormonal agent. But in low volume disease, it didn't seem to provide such a benefit. Next slide. Arasens trial is a global randomized double-blinded placebo phase 3 trial. Once again, it was done in metastatic hormone-sensitive prostate cancer, and those were candidates for both ADT and docetaxel. And here we used this innovative molecule darolutamide that was combined with chemotherapy. So the chemo hormonal combination, and along the control arm was a placebo arm. Docetaxel was used in both the arms, and the endpoints primarily were overall survival with multiple secondary endpoints, but probably the most important is time to pain progression, time to symptomatic progression. So the most important thing that I must highlight here is that adverse events between both the arms were almost identical. Next slide. Next slide. So as you can see here, there was an improvement in the darolutamide arm that was combined with chemo as well as the any conventional ADT that the physician used. And here we can find that the overall survival was in the range of 13% improvement with a hazard ratio of 0.68. So this seems to be quite healthy, and the difference seemed to be more with time. Next slide. And probably the most important thing is benefit was seen in all subgroups. Next slide. So probably this secondary endpoint with respect to time to castrate resistant prostate cancer. So how we can delay the progression of the disease to castrate resistance, and here we find that darolutamide seemed to succeed a lot, and it delayed the progression to castrate resistance. There was 64% risk reduction. That is massive in many ways, and the time to pain progression, it also delayed any development of symptoms, primarily pain. So there was 20% risk reduction with the addition of darolutamide, and it also delayed the time to first subsequent antineoplastic therapy. So the duration of response with this treatment seem to be more and seem to be persistent. So these are very healthy, healthy data that we can extract out of this trial with the use of darolutamide. Next slide. So, in a way, the rapidity of response was also very prominent. And as you can see here, the PSA lowering was also very healthy. And there was a very swift improvement or the in the downward trend of PSA as well. Next slide. Uh, Next slide. And we all understand that this biochemical response correlates with overall survival as well. And this is understandable, and this which is what we have learned from our experience as well, that the more rapid is the fall in the PSA, the higher is the response, and the better is the overall survival. Next slide. And this is quite heartening to see that the PSA even becomes undetectable at times or fully normalized at times. And this was found in almost two-thirds of our patients. So, and this rapid fall as well as the normalizing of PSA seem to perceive for a very long period and with no disease progression at times. Next slide. Next slide. Next slide. Next slide. This is almost a repetition of the same, but this was actually highlighted in the low volume disease. But whether it is low volume or high volume, we see a similar trend. The lowering of the PSA is swift and it seems to be persistent, and it results in delay of development of castrate-resistant prostate cancer, both in low volume and in high volume disease. Next slide. Next slide. Next slide. Next slide. So the thing is how to decide how intense we should be without treatment, and this probably is directed by the volume of the disease, high volume or low volume. By high volume, there is a high risk of development of castrate-resistant prostate cancer within a short period of time. So probably in these cases, we need to be more intensive. Definitely, the age and life expectancy also matters a lot. So if the patient has a projected survival of more than 10 years, probably we need to be more aggressive in these cases. And probably the chemo part will remain with us, but we need to add better molecules like darolutamide to intensify the response. Next slide. So we understand that we are moving up the ladder. We are providing better coverage with strong hormonal agents like darolutamide, in addition to utilizing the conventional taxane like docetaxel, along with our anti-androgen therapies like GnRH analogs or antagonists. And this combination provides us with a very good overall survival, a rapid PSA response, as well as a delayed symptomatic progression in our patients of hormone sensitive cancer if these are utilized in the first line itself. So with this, I thank all of you for patient hearing.
Thank you very much, sir. Thank you very much. And it is very much insightful. Earlier, Madam has given a good note on aeronaut, and now it is your how to decide doublet and triplet and in various situations. So with this, I'll look forward for any question if there is any question from the audience. I think as of now, there is no question. So with this, can I close, sir? And Smita, madam, can I close now?
Yes, of
Yes,
course.
sure. Thank you.
Okay, thank you very much, sir. Thank you. Have a wonderful evening ahead and good night.
Thank you. Good night.
Good
Good night, madam. Good night, sir.